The intervention that you described must have taken a lot of time. Can you tell us about how much time was required per patient?
So the initial interventions where the plans were developed, this on average took around 1 hour. So although it does sound quite comprehensive, a lot of the conversation did flow quite organically. Um, after the first appointment, follow-up appointments were booked 1 week after each opioid dose taper was planned to ensure safety and to check in with the patient. Those follow-up appointments were typically shorter as they were largely a check-in and they were guided by the patient's needs.
Hmm. And what about opioid withdrawal? Was this an issue?
So we definitely considered opioid withdrawal as a part of ensuring patient safety in this research. Our opioid tapering rate, as I mentioned, was very gradual and informed by evidence-based guidelines. And our pain specialist reviewed all of the opioid tapering plans for safety. However, if a patient did develop opioid withdrawal symptoms, the pharmacist paused opioid tapering, gave education to the patient on how to overcome these withdrawal symptoms, and if necessary, the patient was put back on a higher opioid dose to, at the end of the day, ensure that patient safety came first.
Hmm. This is an important point. Can you tell us a bit more about adverse events and patient safety monitoring during the study?
We had patients who experienced opioid withdrawal symptoms, but we also collected all of this information and reported on that in the findings of our paper. We also collected the incidence of side effects from the opioids themselves, and we looked at the combination of adverse events from opioids as well as opioid withdrawal symptoms as an aggregate indicator of patient safety. So when we balanced these two outcomes, we did find that there was no meaningful difference between the intervention and the usual care arm when it came to patient safety.
Hmm. And now, Jonathan, what did you find and how did you assess the impact of the intervention?
So this was a pilot study. It was a lot of work, and we just want to make sure it worked to start with. So our main intervention assessment was, did patients successfully taper their opioids before surgery? Can pharmacists do this task? We didn't have any data showing pharmacists tapering opioids before surgery before, so we wanted to make sure that that was possible before we did a larger definitive trial. And we also found that currently GPs or primary care physicians are generally responsible for opioid tapering, but that's not their happy place. They were not comfortable. They did not want to spend their time on that. Well, when we asked pharmacists, this was something they were quite keen to get more involved in. So we implemented the intervention and we said, did it even work? Did the patients taper their opioids? And we found that those in the intervention group, 90% of them tapered at least 50% of their opioid dose before surgery. So 90%. And for the usual care arm, it was only 17%. And as a researcher, it's very rare to see such large differences. 17% versus 90%. I suspect we over-recruited because no one expected it to be that successful. That was the primary way we assessed the impact was did they actually taper it? And we found by a very, very large margin, yes, partnered pharmacist opioid tapering um, definitely reduced their opioids before surgery.
Hmm. These are very impressive numbers. Can you say anything about the outcomes of the study, quality of life, for example?
I'll talk about some of the other outcomes that we measured. I'll talk about the ones most related to the intervention, and then I'll talk about quality of life. So we found that if we did taper their opioids, so those in the intervention arm, because their opioids are tapered before surgery, they had much less opioids in hospital, at about half the total opioids dispensed on discharge, and even 3 months later, those in the intervention group were much less likely to be on opioids than those who were on the control group. So we saw across the board, even 3 months later, their opioid use was much, much less than the control. And we found, well, if your opioid use is much less, maybe there are some other flow-on effects on quality of life that you measured. So as you've highlighted. It's not powered for this, but we did see very promising results. We found, firstly, that the length of stay was shorter in those who received the intervention, and we all know how difficult it is to impact length of stay. So the intervention group was around 4 days, while the control group was around 5.6 days. And even 3 months after the intervention, 3 months post-surgery, those intervention had improved physical function as measured by the PROMIS 29 tool. And they also had improved overall body pain intensity. And this is 3 months after the surgery when they've been tapered. And again, it's not powered for that. So we do have to be a bit cautious, but these are very promising results.